medical school at the University of Iowa, and I did my orthopedic residency at the University of Iowa. And then some people choose to subspecialize, which I did. I had the great privilege of being able to do a rotating or traveling fellowship through the experts in this country and in Europe for total hip and total knee reconstruction. Places I went in the United States was Harvard, and over in Europe I went to places like London. After that, I then joined Des Moines Orthopedic Surgeons to specialize in reconstruction hip and knee. Also extended that to shoulder, and it includes mainly mostly total joints, but I also have a large practice in sports medicine where we reconstruct shoulders and knees through the arthroscope. I'm a better surgeon now than I was at 30 or 40. And with those years of experience, that helps both professionally and personally. By professionally, I've seen things come and go. I know all the old techniques. I know all the new techniques because I keep up to date. But the advantage of knowing all the old techniques is I get a glimmer or a glimpse earlier than some people of knowing which of the new techniques are going to work and which aren't. Because what people don't understand is we get advertised new to us, and so it's our initial intuition to believe new is better. Not always so. In medicine, oftentimes, only 1 of the 10 new things last. So the sooner you can understand which is good and which is bad, the better it is for your patient. And my other experience just in life is I know more about living when I'm at this age than I did when I was 30 or 40. I know what people are thinking because I've listened to them for a long time, and I've lived through some of the things. So I think I can anticipate their needs and hopefully more carefully match their goals. There's a new technique now called the direct anterior as opposed to just the anterior. People may understand that term because it's out there in the public. What they need to understand about it, it was devised to hopefully make the recovery a little quicker and slicker. When comparing it to our conventional techniques, that hasn't been proven yet. But it's a reasonable approach. So because people wanted it and it was as good but not necessarily better yet, I went out and learned how to do that and can offer that to my patients too. My wife got us involved in a missionary work through our church. This is where we have a sister town in El Salvador, same place each time, a very poor canton as they call it. And I've agreed that yes, we as a couple should participate in that. She has been the boots on the ground. She goes there 2 times a year. She knows these people personally, and we said, how can we be involved? So we've donated things like water barrels so they can have clean water, donated money so kids can go to high school. But more importantly, we thought, well, what should we really do? Well, she was a nurse, I'm a physician, so we know medicine. These people don't have any medical care, but she's seen some other small villages that had some small triaging clinics. We thought, let's do that. I like to view the patient as an individual and see their problem they come to me with in context of their concerns, desires, and expectations. And then with my experience, hope to give them the best outcome to meet their goals each time.